Good afternoon, everyone. I am Rahul from Abbott Vascular, Chhattisgarh. I am welcoming all of you for once again for Complex Coronary Econclave Series 12. Today we have a very expert panel, two expert panelists from Chhattisgarh, Dr. Javed Ali Khan, Senior Intervention Cardiologist from Ramakrishna Care Hospital, and Dr. Dilip Ratnani sir. He is a CSI President as well as Senior Intervention Cardiologist from Sri Shankaracharya Institute, Bhilai. We have two speakers today, Dr. Rajiv Lochan Bhanja sir. He is a Senior Intervention Cardiologist from Apollo Hospital, Bilaspur, as well as we have Dr. Dhananjay Kumar sir. He is yet to join, but he'll join after 10 minutes. So the flow of the program we'll start with Dr. Rajiv sir's presentation. First, after that, there will be a discussion on this case, and then we'll move to Dr. Dhananjay sir's presentation. Over to you, Dr. Rajiv sir. Please share.
Thank you, Rahul. Sir, namaskar, sir. Javed sir, Doctor.
Namaskar.
Sir. Sir, actually, my patient is a 68 year.
I think you are not visible to us. Your name is visible on the screen. Yes, it's okay.
Now is visible. Yeah.
Now you are visible.
So actually, my patient is a 58-year female.
Sir, you have to share your PPT.
So click on share screen option. At the bottom, there is an option, share screen, green color.
Few minutes before he has shared the screen, it was visible, his presentation.
Yes, sir. Yeah. So, sir, make it full screen and go to first slide.
Sir, this lady presented to the emergency with acute coronary syndrome. TROP-T was positive.
Rajiv, can you make it in a presentation mode? Make it slightly bigger.
Sir,
Full screen.
It
Full
is
screen.
not visible, sir.
No, it is visible, but it is not in the presentation mode.
Okay, sir.
Make a full screen.
Okay, sir. इतना ही आ रहा है सर now.
No problem. Go ahead. Go ahead.
Sir, basically this patient presented to the emergency with acute coronary syndrome, chest pain, 68-year female, and echo shows about 45% LV function, mild MR, and she had triple vessel disease. Basically, you can see the LCX, LAD is tentable, and I asked for actually revascularization. CABG patients refused, and patient take home the patients to come to home. Basically, they have multiple issues, so they decided we will go for angioplasty. But the L6 was calcified, LAD was also calcified. So because at that time IVL was not in my lab, OP and LC also was not in my lab. So I thought I will try first left circumflex. If I will succeed, then I will. LAD was not that much a problematic for me. Main problem was L6 long cells calcified. So then I tried. This is the LAD actually.
Rajiv, it will not play your videos. It will only be, the frame.
So, but now it is
No, it's
Video-
not. It is not playing. It is only slide, one frame which is visible, not the video.
Okay, sir. Okay, I'm trying, sir.
Huh. Yeah, better.
Now, is it coming, sir, in video?
Yeah, it is visible and it is playing the loop.
Okay, sir. Sir, actually, like normal PTC, I just took across the wire immediately. And then I started the pre-dilatation with normal, how we'll going routinely to actually I'm trying with 2.5, but I'm not able to cross. Even I tried with 2, I'm not able to cross. Then I started from the beginning with 1.5 balloon, and I going to dilate the artery. You looking like I can cross this stand, but unfortunately I tried a lot. I'm not able to cross this stand. My guiding was out, and even I did a body IR, still I am not able to get the balloon. So I leave the patients. I thought it is not possible. You can go for CABG. Again, patients presented after 1 week severe chest pain. Still they refused for CABG. Then this time I asked that no, it is not possible. So I arranged OPNNC and IBL both. Then I have taken it in one view. I am right. This is again I have started. Again I try to cross with OR immediately. Then started again balloon, because last time already I did the balloon to the LCX with 1.5A2. At this time I am able to cross the balloon easily. OR out again, difficult case for me. Then I again rewiring the LCX. Now I started before I did the IVL, I took a 2.5 into 15-meter balloon. Then I dilated, well dilated with high pressure, near around 16. Even from the proximal to mid distal. This is the IVL actually. This is the IVL balloon. Actually, what happens, because this was my first IVL balloon. 1 month back I did this case, IVL. So what happens? They exactly once I pre-dilate, try to dilate the mid segment. So patient have started hypotension and severe chest pain. So I pull little bit proximal. After that, it was not possible to cross the main lesion actually. But still, then IVL balloon was punctured. Then I tried to recross, but it was not possible. So I have to took another balloon, then dilate proximally and distally very nicely. After that, I thought I could succeed to cross the. You can see this is the balloon in the proximal part. It will see the two markers, and this is the basically OPN and IBL balloon. So then I thought I can probably I will succeed in my crossing the stands. You can see still I am not able to cross the stand. It was again hanged up in the proximal part, osteoproximal part. Then again I did the body OR. Then after that stent was crossed easily. This is the stent with body OR. But after that, in stent V also it was not properly opened to the proximal part. So I have to use again OPNNC to the proximal part and went into the 40 atmospheric pressure. It was 3 and 15 millimeter of PNNC went up to 40 with result was good. You can see the stent's position is very good, and this is the giant stent 2.75 into 33 millimeters giant stent. And after that, same setting I did LED, and LED normal, just like routine angioplasty, and sorry, and patient. But after that, because I did femoral, again patient had hematoma, so I have to keep the patient for 2-3 more days. But finally, I'm able to succeed the both the lesions nicely. Now after 1 month, patient again came for follow-up. LE function is near about 45 to 50%. No complaint. Hematoma site is normal, and patient walk without any problem. So it was a first case actually for IVL. So now I have 3-4 cases I did IVL within 1 month. They are all good, because I probably it was my first patient, so at that time I have to face a little more difficulties. And in our lab also, this is everything is not available like OPN, NC and other things. So but patients, it was a difficult case. Took 2 hours for me first case, and huge calcified cells.
Dr. Banja?
Sir.
Yeah, in fact, now just I want to tell you that if you think retrospectively and you think that this case, suppose you want to take now, and what thing is in mind that you will change it?
Probably, I think even without IBL also, even we can pre-dilate in OPN and say probably I can succeed now.
So here I just want to know from you. Number one, why first IVL balloon has to be ruptured and then taken back? It was not deflating. What happened?
What happens once I to actually what happened before when first patient was admitted few days back. So I did pre-dilatation. I am not able
that
to
I
cross
understand that you did 1.5
next time when
dilatation.
patient admitted, I thought I was able to cross the balloon nicely. So I thought my balloon will also cross to the distal part. Then I will first dilate the distal part, then proximal part. But when I started the dilatation I will balloon, patient started chest pain and hypotension started. So what happens? By default, I pull out the balloon to the from the mid segment to the proximal segment. Then what happens? I try to cross the mid segment, but I am not able to cross. I tried a lot, but I am not able to cross. So in proximal segment again, I some pulses I have given. Then I took the balloon.
So you
outside.
just taken out the first balloon and first lithotripsy balloon, and then took another lithotripsy balloon in that.
Exactly.
Okay. So
then I saw in outside that once I give a contrast and fluid, I saw balloon had punctured.
Okay, so what? So that is just because of the calcium.
Calcium, sir. Because of the calcium, it was a huge calcium was there in the mid segment calcium.
Rajiv, I just want to take the opinion of Dilip. Dilip, do you have any other idea? Do you have any other strategy for this particular case? Because I would have been more comfortable by using the stuff for this particular patient. One, having the guide extension catheter with me, and thirdly, the cutting balloon or angiosculp kind of thing, for this one.
Yes, yes, that's what I coming to. That the case selection in these cases we should think. And another thing that he took lot of risk with OPN balloon 2.75 he took, I think. And if you really see, the size of the artery was not more than 2.5.
No, sir, sides stand to accommodate very nicely, actually, sir. 2.75.
But you see the lower one, the disparity is visible.
Maybe, sir. But it was very 2.5. I have dilated 2.5 into 16, sir. Pre-dilatation. My balloon was, when I took the balloon 2.5, 16, I went out of 16.
Okay.
So it
Rajiv,
is said it-
why didn't you take this one guide extension catheter for this crossing? Because you're very lucky. You're trying to go into the circumflex, and half of the balloon was into the left main, half of in the circumflex, etc. Sometimes there is a chance that left main can dissect, etc., etc. A lot of things can happen.
Sir,
So,
actually looking like that, when I saw the NGO, I thought I will cross. But once I started the case, now it was very difficult for me to cross because calcium junk was there. So I'm not able to.
better,
One look,
better the dictum is better you start with gradually dilating, and in case 2.5 balloon crosses and then dilate fully, most of the time it can accommodate and take the stent most of the time. Or
but I'm not able to
balloon.
cross. Sir, even in body wire, it is very difficult for me.
Okay.
From the osteoproximal segment, I am not able to cross this stand.
Because this IVL balloon is very bulky. In case you'll use, you should be little careful, slightly difficult. So proper pre-dilatation, I think, is better. But anyway, your choice was IVL. I would have done with the Rota and
Rota also is good choice, sir.
yeah, and
So,
yeah.
Rota
Rota
and
also good choice.
cutting balloon,
And
etc.
artery was straight.
Course
Artery
of the artery was straightforward.
straightforward, sir. Artery
Yeah,
was straight.
there was no
Rota
torture,
also is a good
no
option.
band, etc.
Exactly.
Anyway, it's a personal choice. No
No,
problem.
sir. Rota is also choice. Yeah, I did the option because that's why it was my first case. That's why I
Yeah.
want to show
Then
my experience actually.
you must have felt this IVL balloon is quite bulky.
Sir,
Sometimes
I
it gives
think
lot of
IBL now
pain.
I did 3-4 cases IBL. IBL is nice, sir. Now I did one case RCA. Even after post dilatation, I am not able to cross the stand. Then I postponed the case. Again with IBL, it was very nicely I able to cross the stand. Only at 10 pulses, it was very nicely I am able to cross it. Only single point and very good case, sir.
So
Right.
can I ask one thing? In what condition you prefer the IVL over the Rota, and what are
In
the
short, actually, sir,
anatomical reasons?
Ectos are tortuous in short segment. For a short segment, where I am found able to not cross the stand, and when the artery is tortuous,
Right.
and that's the very difficult to do with Rota, sir.
I know. So the tortuosity is one, and in case it is a nodular or the very specific
Specific points, sir.
kind of thing,
Sir.
in those situations it can break. IVL can break better.
Break better, sir. We didn't have Rota also, sir. So I thought I will
No, it's all
try
right.
with
It's all right. This is safe. This IVL is safer than Rota.
even
And
sir.
learning curve is very short.
Even sir, one LED cases I did. If I tried a lot with 2.5 after dilatation with 2.5, still I am not able to cross. Only near about 8 to 10 proximal to mid segment, basically at the juncture of the D1. Then I postponed the cases again with IBL. It was very nicely, only 20 pulses. It was very nicely crosses and post dilatation the stand very well opposed. Probably Rota also can happen, but because as Rota is not available in our lab, and IBL
What size of IVL you have used? The balloon size was
2.5, sir.
2.5.
They have a fixed size, sir. 2.5, 15 or you have used.
Finish.
I just want to know if you are not able to cross with suppose IVL balloon was not crossing. So should you use cutting balloon at that point of time?
If I am not able to cross, the definitely cutting balloon will help.
Yeah. Wolverine is better. I have used Wolverine and angiosculp. Angiosculp
Very
is
good.
slightly bulky,
Sir.
but Wolverine is definitely better than this one.
And sir, in this case, probably if I could have tried with the guide extension, Godzilla probably will help for my crossing.
I would have taken the Godzilla right from the beginning.
Probably I could have succeeded from the first time.
Then, most of the time the operator is independent. You would be doing all alone. Sir. You don't have the hands available to you. So in all those situations, you can't invite lot of complication. This is the problem.
I probably from the first time I could have succeeded with Godzilla.
Yeah. So most of
without
the time,
IBL also.
I prefer to take the guide extension catheter right at the beginning. Once I decide the case, and I think that I might require the guidezilla, better to go with the guidezilla right from the beginning.
Sir, one question actually, Ratnani sir, one just what you are asking me about this guidezilla. One just 15 days back, I am trying to do a right coronary artery. It was 100% acute influal stemming. And about Godzilla, just I am telling you Godzilla. So I tried. I'm able to cross the lesion, and even I export. We did export thrombosuction done. Then I tried to put the stent. So stent was not crossing. Then I did primary. First I tried to do a balloon, 2.5 20 millimeter balloon. I did the balloon. After that, my wire was inside the artery. It was not out. Then I tried a lot with the stent, with body IR. Then after that, I am not able to cross even 1.5 meter balloon also. Finally, I postponed the cases. Then patient went to this time I'm about the Guidezilla. Then I took Guidezilla. I thought I will succeed with Guidezilla. Even it was also not possible. Then I postponed the cases. Artery was opened. TB3 flow was established. Then I postponed the cases. He had also a right bifurcation lesion with LAD and diagonal, critical lesion. Then patient took to Hyderabad this time. Then Dr. Manoj Agarwal, Dr. Manoj Agarwal. Then they called me that it was not able to cross. What is the problem? Then they also tried there in Hyderabad. They took 1 millimeter balloon, 1.52, then OP and NC balloon. Finally, they were able to succeed the RCS stent. They took a huge time, then postponed the LAD diagonal lesion. Sir, what is the problem? Even after crossing the 2.5 millimeter balloon, what is my problem? Why I am not able to cross? I can, if you ask me, I can show the cases in the.
Yeah, it's better, better to show. Sometimes there's a plaque modification kind of thing, Once you have dilated with the balloon, sometimes you shift the plaque, and the plaque morphology is such that it does not allow your balloon to go
After
inside.
that, sir, I am not able to succeed. I am not able to cross the balloon. So it was a horrible, sir, in primary PTC in the middle of the night. Very difficult. So artery was huge and in the only small focal point.
You have to show that case,
I will show you, sir.
Yeah,
Next time, sir.
Better you show, because that is a practical problem. Sometimes it happens.
It was actually no one would believe na that say after crossing dilating with 2.5 minute to 20 minute balloon, why it's other balloon is not going.
Yeah, I mean it's a practical problem, but it happens.
So, but in acute cases,
sir, in this cases, sir, what is your opinion, sir? Suppose you have stock in the lab.
I mean, dissection is one. I mean, suppose you have created a dissection. Sir. While dilating with the bigger 2.5 millimeter balloon.
But my balloon has not come out, sir. My OR has not come out.
No. I can understand. I mean, how will you justify this problem? Once you have crossed with the 2.5,
because you are the expert in all these fields, sir. Just I am asking.
No. Out of curiosity only. This is what I personally. I'm just speculating what could be the reason. One is. Suppose you have created a dissection while dilating with 2.5 and the flap must be obstructing. This is one possibility, but you should be able to see the dissection area.
Sir, I am not able to see. I have that case with me in my
and sometimes the plaque modification can take place. Suppose you are dilating from distal to proximal, and in the proximal area you have dilated and the plaque shifted, and that would be obstructing the second balloon to go in. This I'm just only presuming.
Sir, in this case, suppose I didn't get TB3 flow and acute influal STEMI. What is, sir? What should I? What is?
I personally think then you should rewire. I mean, try to rewire the lesion again with the new wire, and try to thread the balloon over that. That is what I can think of.
No, sir. My question is.
I want to ask one question. What was the guide catheter, sir?
Right.
Jodkin's diet, na? That's the one the common problem when you are using JR catheter, and with that you are using Guidezilla or guide extension catheter. It will not support. So you have to first keep some better supporting catheter like AL2 So it will then it will help. And if you are using GuideZilla or guide extension catheter in a JR, if the uptake of the RCA, sometimes uptake of the RCA is so acute that it will not help. So you have to just exchange the guide and then use GuideZilla. It will certainly cross because your case was primary. So I don't think there would be any dissection or any other complication that would have complicated your case. The simple problem that occurs with RCA is the acuteness of the origin of the RCA, and you have to choose a stable guide catheter, and AL2 would be the best option in such situation where you want to use the GuideZilla or guide extension catheter.
Yeah, I mean, well taken, Dr. Dhananjay, I think, right?
Sir.
Yeah,
sir.
I mean, your point is well taken. The guide should support properly before the balloon goes in. And in case it is not supporting, suppose sometimes even the GuideZilla will not support. This is well taken. But not the important thing is AL2, you know, AL2 is basically, it's a tricky catheter. You have to use very properly, but in case you don't have any other chance, you're not able to cross with the JR guiding, even using the new balloon, GuideZilla, etc., then you have to rewire and exchange the guide catheter and then try. I mean, there's no reason that you should not be able
another few other options are there, sir, like balloon anchor ballooning technique. You just put another wire in side branch, some small side branch, put one a smaller balloon, inflate that, and now try to push
this anchoring balloon is basically to increase the support of the guiding catheter.
Support. Yes, sir. Yes,
basically to increase the support of the guiding catheter.
Support.
Guide support is must. Proper guide support is either by GuideZilla or by exchanging it to the AL or some other technique, anchoring balloon or buddy wire or whatever you want. You need basically the guiding support.
Sir, the most common
support was there. I will show you case next time. Guiding support was there.
Rajiv, in case you will show the anatomy of the RCA, then I think we'll be more wiser and we can give you the better.
Sir, I will show in next time. I will show the cases actually.
Sure. I mean, that is a very learning point, you know.
Actually, sir, we are doing routinely this type of cases. Actually, why I felt I didn't know, but GuideZilla, I don't want to remove the wire and I don't want to put the wire again.
Sometimes it happens. There's no doubt about that.
So I just want to highlight. Recently, the case was presented where situation was like this only. So it was highlighted that it is, of course, the rotablation is contraindicated in acute coronary syndrome, but it can be tried also if there is no much thrombus burden in such type of cases. Only thing is you have to take a microcatheter and exchange rota wire.
Sir, what is the case? What is the role of IBL in these cases?
In acute cases, I don't know. I don't have any.
I don't know, Rajiv. I mean, that depends upon the severity of the calcium.
Okay, sir.
In case you can think that huge amount of calcium is there, which is obstructing and which is creating problem. As Dilip has told, though the rotablation is contraindicated and not advisable in acute coronary syndrome, where there's a lot of thrombus burden, but it's not absolute contraindication. In case you have thrombosuction done and most of the thrombus you have removed, then and
secondly, you don't have I just want to know how the lithotripsy balloon will reach there.
It is difficult. Then it will not cross.
So that is out of question, I think.
It is out of question. In case you are not able to cross with the regular balloon, there is no question that the lithotripsy balloon will ever cross.
Okay, sir. Exactly. If I am not able to cross the normal balloon, then there are the bulky balloon. How can we cross it?
Yeah. I mean, so that question is out of...
exactly.
In such situation, you have to use multiple wires. If you are able to wire two wires at least, and now starts ballooning with the smallest balloon, 1.2, 1.5, and start cutting with the side
balloon also. Still, I am not able to cross.
Okay. I mean,
when 1 millimeter balloon is not crossing, you have to do. You have to do
rewire. I mean, what I'm telling you, Rajiv, the best thing is to just take out everything as you have done and try to rewire.
Exactly, maybe, sir. Maybe.
And rewire and go through the proper channel.
Exactly. I can do all this thing.
Theoretically, it is said that when wire is crossed and nothing is crossing, then theoretically, I am saying you, the laser is the best option in such type of cases.
Sir.
But
Theoretically,
laser, Dilip,
it is the academic point of view. I just
Yes,
want
sir.
to say.
yeah, but laser, unfortunately, we don't have in many
Yeah,
other
that is. That's
facilities, you know.
so.
Uh,
It is
No,
the
no,
only
you are not
condition
the
where
only
laser
person
will
who are
work.
unfortunate for this, sir.
no. I mean,
Not many
95%,
Yes, sir.
98% centers will not be having the laser. at the
centers do
moment.
not have, sir. Do
Just
not
for the
have
sake
laser
of discussion,
facility.
I just wanted to bring
Yeah,
in this.
this is
Sir,
one
sir,
option
sir.
available theoretically in case you have. But
Sir.
before proceeding for laser, you know, better to make sure that you have done exhausted all kind of the conventional method for crossing the lesion, like exchanging the wire, taking the guidezilla, having the different guide AL1, AL2, whatever you want for the better support, buddy wire, whatever you want,
Sir.
and start with the smallest balloon available, then proceed. And if nothing is possible, then of course what Dilip is telling is right. Start and go for or send the patient for laser.
Laser. Sir. I am sharing my own experience, sir. But if the lesion is so tighter that you are not able to push even a small 1 mm of balloon, in such situation, if you are observing a high thrombus burden, there is some illusion. There is some illusion. In such situation, the thrombus is not so large because of the narrowing of the lumen. You are observing such type of thrombus. So in such situation, if you are able to cross microcatheter beyond the stenosis, just take a shot. And if you are seeing that the whole lumen is opaque like the A, so you will able to just judge what is the amount of thrombus. If thrombus is small, then you can use rota in such situation also. I am not, it is not recommended anywhere, but I am just suggesting that if you are judging that the thrombus burden is low, and how you can judge this one, because if the microcatheter can cross the lesion, you just put 2 ml of dye and just see what is the amount of thrombus burden. Then you can use even rota ablation in that situation.
Just want to know whether you are using radial route or femoral route.
Sir, are you asking to me, sir?
In that particular case, whether you were on radial or femoral route, when there was no support and you could not succeed. So sometimes we have to change the route also. Radial does not support nicely. So you have to change through the femoral route. Many times we succeed.
Sir.
Exactly, sir. This case was done by femoral again, and they have succeeded also with some method, because they asked me over telephone why you have not able to cross, what is the problem, what is the problem you faced. Then they select the guide, for femoral, everything they used.
Anyway, it was a very good discussion, and I should
Thank
say
you, sir. Thank you.
of learning points.
Thank you.
Thank you.
So, good afternoon, everyone. So, Dr. Dhananjay Kumar sir is here. So, I would like to introduce Dr. Dhananjay sir. Dr. Dhananjay sir is Associate Professor and Senior Intervention Cardiologist from Narayana Medical College, Sasaram. So, he's going to showcase his presentation. So, over to you, sir. You can share your screen.
Is my screen is visible there?
Yeah, now visible. Yes, yes.
So, it is visible. Just make it full screen, sir.
Okay. Okay. Good afternoon, respected chairperson, delegates, and speakers. This was a 46-year male presented with unstable angina.
Dhananjay, can you make it on the presentation mode?
Yes, yes.
Okay, great. Make it.
Okay, sir. Okay, sir. So he was non-diabetic, non-hypertensive, and non-smoker. We did his angiogram. This was his angiogram. The right coronary artery was normal and giving retrograde class 1 or 2 retrograde to left system. LMCA distally was 20 to 30% narrowed. LAD was obstructed from ostium, total occlusion from ostium. LCX was 70 to 75% narrowed in proximal part, and high OM or ramus was critically stenosis at ostium. So our plan was to open the LAD, do the IVUS, and after that we will have to judge whether we have to go for dedicated bifurcation or provisional bifurcation. We have started doing LAD. It was a CTO lesion. We started wiring with filter XT. We were initially successful in crossing the filter XT in the initial CTO part, and we just wanted to check that what is the lumen of distal segment. So the distal segment was not very much large. It was a smaller, but even after that we did some balloon dilatation, but even after 1.2 mm balloon, 1.5 mm balloon was not crossing. We tried hard, but we are not able to cross that. Then we have started doing so we took rotacatheter 1.5 bar, did rotablation, did sequential pre-dilatation with 1.5 to 2.5, and after that we got this much of flow. Distally, the vessel went into the spasm, and the distal flow was not adequate. The distal lumen was not adequate to accept the stent. So we decided to leave it as such. This was the final left-sided. This was the final left-sided flow. So we decided to leave it as such. Now we did the sequential. Before going to sequential pre-dilatation, we did IVUS to left LCX, and it was critically stenosis. About 75 to 80% of plaque burden was there. It was fibrous plaque mainly. I have IVUS run in distal most of this PPT. I will show you that. Unfortunately, I have not sequenced this because of the constraint of time. So I did plasty from LMCA to LCX. This is a long 3x38 Giants alpine stent, and sequentially post-dilated LMCA to 4.5 balloon. And after Post dilatation, final IVUS run was taken, and we leave this case as such for 1 month. After 1 month, we again took the case. This was the LED. Now after sequential pre-dilatation, we put another 3 into 38 mm stent, Giant Alpine, and just did the tap, a staged tap, and give a after giving FKBI, I gave 2.75 into 15 mm drug-eluting balloon of magic touch to the high OM or ramus. This was the first. This is the drug-eluting balloon. Initially, I have decided to give kissing balloon like trifurcation. So I started with the engaged another catheter, but it was going cumbersome, and the ramus intermediate was not so large. So I finally decided to leave it as. So this was the final result. So now over to you, sir.
Naranjan, nicely done case. Couple of things I just wanted to know from you. Initially, you crossed the wire to the LED, which was CTO. Then you started opening the LED. Then finally decided to go with from the left main to circumflex, right?
Sir.
And left the case for a month. So, couple of things. One is that while you are opening the circumflex from left main to circumflex stenting, because the LED was CTO, there's not much problem. But the OM or the ramus kind of thing, which was coming out very early, you tried to save the ramus. Did you put a wire into the ramus?
Yes, sir. I said, yes, sir. Yeah, I saved that. Even I pre-dilated that segment.
You pre-dilated and put the wire into this one. In case of any emergency, or in case the lesion progresses or increases, then you can do the tap kind of thing.
Sir.
Okay. And later on, after a month, then you have done the check angio and put the stent into the LED. And this stent from to the LED, I mean, you have deployed from the left main to LED or the ostium?
Like tap, sir. 1 to 2 starts inside the LMC stent.
You have done the tap.
Sir, I have done the tap. Sir.
And magic touch you have done to the ramus.
To high OM, sir.
The high OM. So at that time, while you're doing the magic touch, after that, have you done some kissing or something? Because you know what happens while you are doing the magic touch or any kind of ballooning into the high OM, then you can distort the circumflex stent, you know. So,
sir, usually I used to do drug-eluting balloon at very nominal pressure, 6 ATP. Keep it at 30 to 45 seconds, but I usually do not do high pressure inflation in drug-eluting balloon. So it will hardly distort stent starts at 6 atmospheric pressure. But yes, sir, there is chance.
I mean, there's always a chance, because you know you have to go through the start of that.
I could have done, sir.
Yeah, definitely. I think you should have done this one. You should have put a wire into the circumflex and one wire into the OM and do the magic.
Sir, wire was there.
Yeah,
wire was there. Wire was
and while after doing this magic touch, you should have done a
Correct.
kissing kind of thing, because, the circumflex is the life-saving artery. You cannot compromise and you cannot take a chance. Any kind of
Sir,
blockage
you
into the
can see the
circumflex
sir.
will kill the
I
patient.
am showing it on the screen, sir. I am showing it on the screen. The first screen is I am doing giving magic touch
Right,
to the
right,
OM.
right,
Okay.
right.
The second screen is kissing ballooning to the LCX and LED. Okay. And after that, I have completed the procedure. But
Okay.
there is some risk of occlusion of OM also. So
Yep.
I would have to take two simultaneous kissing. One is from the 3 balloon simultaneously in LED, in OM, but either I would have to take 8 French catheter, or I have to take two, one from the radial and another from the femoral side. Then, but I opted to use go with the simple way and come out, because ultimately you have to come out from the lab with the
No,
safe patient, safe.
I think Dhananjay, you did very good job, and you are right that the OM, after doing magic touch in OM, you did kissing LED and LCX. So there is no problem
Sir.
in LED, LCX, you secured nicely. And there may be some compromise,
Sir.
there is no problem because you have to shortcut the
No
process.
problem. Sir.
So
Sir.
ended with the
Sir.
kissing in LED and OM, LED and LCX. That is the final touch you
Final.
gave.
Yeah, I mean, I think
Sir,
that is
sir,
okay.
sir.
If you have done the LED circumflex kissing and you have preserved the morphology of the circumflex stent, then it's okay.
Sir.
How long this case is, since how long, what is the follow-up case? How many days have you follow up the patient?
I think 3 months or something.
Patient came to your OPD next after this.
Yeah. He's coming every
I just want to know you, Dhananjay, from you, why did not you did LED stenting in the same sitting?
Yeah, same question I was wanting.
Sir. Distal lumen was hardly looking 1.5 to 2. So initially I thought due to the chronic occlusion of the LED, the distal flow is not adequate, and this is the reason for a smaller lumen distal LED. So if I will keep the LED open for 1 month, the distal will relatively be bigger than the initial stage, and so I will able to put the distal. There is some chances even the distal vessel is in vasospasm and the lumen is 1.5. If you will put 2.5 a stent, even 2.75 a stent, it will difficult for you to manage the dissection later on. So I decided to leave it as such, and
but it is very difficult. It is very difficult if we are putting a stent in left main to L6, then again you are doing a stent after 1 month. It is very tough and a risky job to cross through the after endothelization, doing kissing, all these things. It carries high risk. After I think simultaneous will be a better option.
What I did in index procedure, I just after potting the I crossed the one wire from the LMC stent to the LED and opened the stent to the LED ostium, so that I can easily able to cross the wire.
I agree. Now what do you think, whether this is the best way to do it or you will want to modify the method? Retrospect.
Sir, it is up to you, sir. Now you decide whether this
what
was
I
right
think
or
is what I think is you give proper vasodilatation properly. LCX should be prepared because you have done rotablation to properly. LED should be prepared. You have done rotablation to LED, and you cannot leave. This is my thinking that once we have done rotablation, you end up finishing that vessel nicely. If you think that distal vessel was not visible properly and was not able to probably measure the width of the distal portion, then IVUS catheter should be taken, and you should study that, and then properly stent should be deployed in the same sitting. This should be the ideal method. And usually we don't leave a vessel where we have done rotablation. This is my thinking.
Dilip, another problem is that suppose after a month, this LED would have been occluded from the ostium. I mean, you never know. The
Never
LED
know.
flow
Sir,
was very timid
Sir, I
one or
accept this
something.
thing.
Yeah, I mean, this is the practical problem, that you thought that you have opened the artery and the artery will grow over a period of time and it will resume to its normal caliber. But it might happen because the flow was limited, it can block right from the ostium. Then you have to reopen the artery and do the same exercise again. Most of the time, Dhananjay,
Again,
the thing is, as per the Indian body is concerned, there is many papers published, regarding the size of the LED. No LED is
sir,
less than 3 millimeter,
3
proximal
millimeter.
LED. Indian
Sir.
population. This is an
Sir,
average, I'm
sir.
telling you.
Sir.
Distal LED, because of the chronic occlusion, it is a slightly underfilled artery and will grow gradually. But in
Sir.
case you are dealing with the proximal or ostial LED, always think about 3 or more than 3. Never think that it will be 2.5 or something. It is an underfilled artery. It might be spasm or something.
Sir.
So, I mean, there was one point that you could have done the same technique at the same time.
Sir.
Opening the circumflex, then doing the tap to this one and the magic touch to the ramus. I mean, anyway, you have done
Sir,
a wonderful
sir.
job.
I accept this.
Final result,
Yes,
final
sir.
result is
Definitely, I
absolutely
accept
fine.
this. Sir.
Acceptable.
Sir.
Great,
Nicely
great.
done case.
Sir. I could have give even drug-eluting balloon for the one month period also, but due to the cost and you do not think so much on the
I
table.
know.
So
When there are multiple problems at our end, financial
Sir.
constraint, this and that,
Sir,
etc.
sir. That's why
I can understand.
decided
That
to
I can
leave.
understand.
Unfortunately, it remained open, sir.
And what was the condition? I just
Fortunately, it
want to know
remained
whether
open. Yeah.
what was the ejection fraction and what was the viability of the LED territory?
Sir, thickness was preserved in the left system, LED territory.
And that was the
that's
old
why.
anterior
And if
wall MI.
ejection fraction were around 40%, 40%.
Old
Sir?
anterior wall MI.
Was the ECG showing?
Sort of, but retrograde was preserving the territory. Retrograde was preserving the territory. So
Okay.
the full thickness, the thickness was not, LED territory was not thin and scarred. It has the
I just want to highlight.
thickness.
I just want to highlight it
Sir.
that you at that point of view thought that the LCX artery is much more important than LED. Was it in your mind?
Yes, sir. Yes,
So
sir.
think that it was
After
a
leaving the
far-fitted
LED
artery.
as such,
I mean,
after leaving the LED as such, I was
Dilip,
thinking about the
I mean,
now.
Dilip, that was very obvious because the LED was
Sir.
CTO and the patient was well maintained and having some mild hypokinesia and the
Unstable
LED
angina.
obviously,
Sir.
the patient was surviving because of the circumflex. Obviously, I mean, the left system was getting the blood from the circumflex or from the RCA.
So it was a homolateral collateral supplying retrogradely to LED?
No,
To
sir.
LCX?
Even RCA was supplying to LED.
Okay.
RCA was supplying to it. Sir.
So left system was very much viable because of the circumflex and the OM. So I mean that was the life-saving artery basically. So that needs to be preserved first.
Preserved first, sir.
But next time, sir, Javed sir.
Yeah, Rajiv.
Sir, it is a doing leftment to LED after LCX stenting after 1 month. It carries high risk. Sir.
I mean, just look. First thing is that you have already preserved the left system circulation by preserving the circumflex and OM. That is most important. Now you are doing the LED. And suppose something goes wrong and the circumflex stent gets disturbed because of some other problem, or the OM gets obstructed or blocked or something, it might create a lot of problem.
So if you don't do LED, what has happened?
Nothing. I think in case you can, most of the people will think that LED is chronically occluded. It is getting the retrograde circulation from circumflex or RCA. Patient is not symptomatic. I will leave it like this. I
So
mean,
he is
taking
lucky
lot of
that he has.
problems should have, taking lot of challenges should have a valid reason for that. In case the patient is very athlete, patient is having class 3 angina, and patient is having lot of problem because of the LED block, then of course it needs to be addressed. Otherwise, is a 70 years old gentleman came with the CTO and LED and circumflex. I mean, I have done plenty of cases, many cases. I have opened the circumflex and the patient is doing absolutely fine. LED is CTO, getting retrograde circulation from circumflex or RCA, and he's absolutely fine. Nothing is happening. Taking the challenges or taking the lot of risk must have some valid reason. That patient having lot of angina, lot of problem. That is why I attempted taking the risk.
Because once you are already you have stabilized L6 is very nice result. Again, you are interfering with the L6 lesion and doing kissing and everything. There is a chances of restenosis. Again, we are now increasing the risk of restenosis of the L6 because how many more you are interfering with the lesion and kissing everything. So definitely we have to follow the patients gradually, but very sequentially we have to follow the patients.
I agree. There is some loss of drug at that point of time. LCX must have lost the drug and some partial endothelialization must have taken place. And after that, you are doing kissing, you are disturbing.
Exactly. After
That
partial
I agree
endothelialization, if you're doing a kissing and everything, definitely it carries a high risk.
Sir, as
No, I am not about asking the results. Result is excellent. There is no issue, but you are lucky enough that the patient didn't have any problem. If something happened to the L6,
See,
then
Dhananjay, you did nice job, but retrospectively, we are thinking what may be the problems, and
Sir.
then how to I think next time if
improve in the better hand
points
next
to be
case,
taken
definitely.
in account.
Correct.
Otherwise, you took a lot of efforts and did very nicely. Strategically, you thought that in OM we will put a drug-eluting balloon and nicely done case. But
just a small example I am giving. Just one nephrologist father came to me in middle of the night on acute interval MI. At that I saw the angiogram. Basically, LED was uploaded 100%. L6 also very critical lesion was there. So I leave L6. I thought I will do the LED lesion. Then I will try after some time. Then after 1 month, 2-3 months, he came. Such I want to do L6 lesion with minimal symptom are there. And at that time, my stent was middle of the left vein. Basically, it was a critical from the ostium LED was occluded. And I didn't put stent in L6 because it was a primary. So I did culprit vessels. Then I am not able to cross the L6. I have to leave because of the stent. I have to leave the patient. Again, after 2 months, patient presented with severe angina. Again, I tried, I failed. Finally, patients during this COVID period, I sent the patient to higher center. Basically, Dr. Praveen Chandra, then
You
they
just
tried.
clarify, Rajaji, just clarify in the first go, when you have done the stenting of the LED, it was on the left main to LED stent?
Sir, exactly totally 1-2 struts. Probably
Oh,
I
I
would
see.
1 to 2 struts.
Yeah.
Then it was
Oh,
very difficult for me to cross the. I am able to cross the lesion, but I am not
most
able
of
to
the
cross the
time it is a
vein.
yeah,
problem. Most
it
of the
happens.
time.
It happens.
Then
Yeah,
they
it
tried
happens.
2-3 hours, 3 hours. They are in the Medanta. They are not able to succeed. Finally, somehow they are advised for the patient to go to Jaipur. Probably that Samin Sharma will come to Samin Sharma. So they also tried. Finally they succeed to do a CABG for this patient because L6 and LED. So it is very difficult to cross the lesion with and doing kissing all these things after putting a stent in all these things. It is not that much easy.
Rajiv, one important thing, this crossing business is difficult crossing basically in the circumflex. Most of the
Exactly.
time, it does not happen with the LED because circumflex is a very
LED.
tricky vessel for all parameters. Its origin, its curvature, etc., etc. And in case you have left 1 or 2 strut into the left main from the LED ostium, 1 or 2 line hanging into the left main, then it becomes more challenging. It happens, we got a couple of cases. Recently, we have done the similar case. where the LAD ostium was stented and 1 or 2 stent was hanging into the left vein. And the circumflex, that was left that time has got a very tight lesion. What to do? I mean, ostial circumflex, similar problem. Then we need to do the same thing, crossing was difficult, then doing the, putting the wire into the LED, then finally doing the kissing balloon into the LED and circumflex. It was very difficult, challenging. So circumflex is very tricky later on.
Most of the time when
one question. Suppose a patient of primary came with a culprit is 100% LED and we are seeing that L6 also critical. So is it possible that we can do a L6 stenting then LED? What is your opinion, sir?
No, you open the artery, LED should be nicely flowing, and then you do both the vessel at that point of time, do LCX first and then LED. So this I have done many times. Whenever there's a ostial LED lesion, you tackle it with the balloon. You do cutting.
But this unstable scenario, is it necessary, sir? Because patients very with
do stenting first in LCX
Dilip,
and then in LED because
Dilip, I still have got a different view. I still believe that the culprit artery, in case of the acute problem, should be dealt first. And I generally don't touch the another artery. Unless there is a compelling indication, like patient is having cardiogenic shock and not improving, and all those things, patient is dying, then what to do? But in case the patient has got a borderline LV function, I mean borderline blood pressure, I personally do, and what is recommended is open the culprit artery, and before discharge, of course, you can do the angioplasty of the another artery after 2 days, 3 days time.
No, sir, the total strategy will change in such situation where you are planning dedicated bifurcation stenting and you are doing single vessel, your whole strategy will change. So if you are thinking you have to do bifurcation, just open the vessel, and if it is flowing good, you can decide doing bifurcation strategy. There is no problem in doing that. You can do, because bifurcation, dedicated bifurcation stenting, if you are using DK crush or culotte, so it will have better result than your later on T and tap. So you can think about the dedicated bifurcation.
Dhananjay, the basic thing we should not forget. Try to make the things and the procedure as simple as possible. Don't try to complicate the thing. I
accept this.
Don't try to complicate the thing and then correcting the thing later on. It is not a good thing, I mean, try to make and keep the procedure as simple as possible. Whatever is needed, do that. In case there is a compelling indication that we need to do bifurcation stenting, that is the need of our power, of course you can do that. But it should not be a routine practice. It should not be recommended. It should not be propagated.
Yeah, definitely, sir. I accept this thing, sir. Yes. If there is compelling indication, you have to do. You can do. You have to do. But try to. Yes, sir. Yes, sir.
I mean, in case the distal left vein is blocking, distal left vein and a lesion is extending into the LAD and circumflex, and you don't have any other option to do both the kissing balloon at acute MI or non-STL MI, elevation MI, then you need to do both.
Sir.
What to do? Otherwise, patient will die. Then the situation is different. But in case ostial LAD this and that, and try to make the things more challenging, more difficult, then dealing the situation and coming out and telling that I have done this one, I mean heroic one, heroic work or something is not recommended.
Sir, okay, 3 to 4 days back, sir, I was doing.
Dilip,
I was sharing one experience, sir. I was sharing experience.
Yep.
Sir, I was sharing just one experience, sir. 3 to 4 days back, I had one patient came with similar unstable angina. He had angioplasty in 2016 with bifurcation stenting to LAD and LCX in AIMS New Delhi, and he came to us with unstable angina. Did his angiogram, LCX were near total cut from ostium, just a single
thread-like structure,
less than the yes, sir, thread like a structure going across the ISR segment, and LED was critically stenosed 90 to 95%. I started wiring. I have to do dedicated bifurcation stenting here. But when I started wiring to LCX, wire was not negotiating to LCX because the curvature, and I was not getting any support. Even to guide extension catheter, you cannot get support from the through that. The only I do not have any side lumen micro catheter. I would have tried, but I didn't have micro catheter that time. So and patient was unstable. So I decided to do LMCA to LED plasty. ISR, I used cutting balloon and prepared the lesion and did LMCA to LED plasty. And I have sent the patient. I will again put the patient to table and do retrograde LCX from RCA to LCX. I have decided to do that on later on. So sometimes you decide to do, but it is difficult to cross the LMCA to LCX when it is critically stenosed. So I have, sir, you are on phone that time. So I did LMCA to LED plasty, and after that I have sent the patient to home, and I have decided to do LCX by retrograde route after 1 month. So I will now call the patient after 1 month for trying to do a wiring to retrograde process. So if it is possible, I would complete the, otherwise I would send the LCX was not very much bigger, so I would keep the patient on that 2 vessel LED and RCA, and if symptomatic I would send patient to the CTVS for vision.
That is most important. I mean, do something to the circumflex if the patient is not is symptomatic, despite revascularization and LED and RCA. Even after that, suppose
Sir,
patient is class 3 angina, class 4 angina, because of this one, difficult to do routine activity,
sir,
of course, then we need to address the thing.
routine.
Otherwise, doing
Sir,
some heroic
sir.
work like retrograde wiring and retrograde PTO type kind of situation, sometimes you might land up into the problem. So anyway, everything
Bigger problem,
what
sir.
is required, and everything what is required must be done, and that is the basic thing. The basic thing we should not
Sir.
forget. Dilip, Dilip, your mic is muted.
Sir, I think Dilip Ratnani sir is not there.
No, Ratnani is there. I can see him. Dilip.
Okay.
Anyway, no, I think he is talking, but it's Rahul.
Sir, good afternoon. Sorry, I got disconnected in between due to network.
Rahul, I think Dilip also got disconnected or something.
Yes, sir. So I would like to thanks Dr. Dilip sir, Dr. Javed sir for his expert opinions for both the cases. Both the cases are very learning for all the participants who are seeing this webinar. I would like to thank Dr. Rajiv Lochan Bhanja sir for excellent presentation, and Dr. Dhananjay sir for excellent presentation and taking time on Sunday. So
Okay,
thank you very much, everyone. We'll see you in next webinar. Thank you.
Thank you, Rahul. Thank you, Dhananjay, for great presentation. Thank you,
sir. Thank you,
Thank you,
Rajiv.
thank you. Sir, namaskar.
Nicely presented. Thanks, Dilip,
Thank
my co-chairperson, and we'll see you again sometime later. Great.
Thank you, sir.
you, sir.
Okay.
Thank you, Dhananjay. Sir, thank you.
Thank you, sir.